Hello, good evening. Joined tonight by Dr. Michael Lovich, and we have 2 hours this evening. We have 2 hours on Thursday evening, and we hope you enjoy it. So just a quick little, bio for Dr. Michael here. He's a board-certified chiropractic functional neurologist and board-certified chiropractic sports physician. He holds an MS in sports medicine with additional training, brain-based functional medicine, and functional movement-based rehabilitation. He has served as a medical director and on medical staff for various organizations and events in professional, amateur, collegiate, and high school athletics. He specializes in integrating the physical aspects of sports medicine and chiropractic care with the neurological and physiological systems that are often overlooked. He's the owner of Delta S Performance, Functional Neurology, and Sports Medicine, with clinics in Denver and Boston metro areas. Right, so with that being said, welcome. Appreciate you doing this for us, and you are welcome to begin whenever you're ready.
Thanks, it's great to be back. I think this is the third time that I've been doing CEs for you guys, and every time it's super fun. Hopefully one day we can do them in person again. So the way we're going to do this one's a little bit different. So the first time that I did it was mainly just lecture about concussions. The second time I did it, we were talking about just a specific part of the cranial nerve exam and a deeper dive on it to see if we can understand it. What we're going to do now is we're just going to go through a really interesting case that I just had over the summer, and we're going to dissect every single step along the way. And we're going to be thinking in our head, okay, so what? What does this mean? How can we approach this clinically? How can you apply this in your patient care? And what do these findings that we do as a functional neurology examination, how do these findings, are these things that you guys can look for in your practices as well? Even if you're not going to do everything as in-depth as I do, at least enough where you're like, hey, that's a thing I noticed. I saw that once. Let's go with it. So here you'll notice that, like always, there's a workbook, because I don't know about you guys. I don't think that sitting and looking at PowerPoint slides is a really effective way of learning, especially when we're talking about nitty-gritty details the way we do in neurology. So I always try to provide some sort of workbook, some sort of interactive thing for you to either print out or sit with, or at least say, hey, here's a blank, I'm looking for this answer. So that way you can stay engaged, especially when we're not even in the same room. So everybody's should have this workbook, and you can reach out to the Delaware Chiropractic Society if you do not have a copy of it. I am going to go through the answer key with you guys. And so you'll notice that some of the words are in a different font. Those ones that are in a different font are the ones that are going to be fill in the blank. So today's topic is clinical neuroscience through clinical cases. And so our first patient, she called up in the middle of May because she was asking if we work with POTS. We do. And so I talked to her on the phone. Every patient that comes to our office gets a 30-minute consultation. Half of it is so that way the patient's expectations are managed. They know what our systems are. They get a better idea of what functional neurology is, and we make sure that what they have in their mind is what we're going to be providing. And then we can also talk to them and find out, are they the right case for us? Whether it's personality or whether it's is it something that we actually can improve? There is no reason for a patient to come into my office just to do an exam if I'm like, you're better off going this other place anyway. Don't waste your money on me yet until that doesn't work. And we've actually had really good success by doing that, because we feel like integrity is a big part of what we do in our clinic. So here, give me 1 second, I'm just moving things around just to stay organized and during the presentation. But okay, we're good now. So we're all going to pretend that we have JNAP now, and you get all your intake forms online ahead of time, 48 hours in advance, because that's what we request. So 2 days before she comes in, she sends in her paperwork. The day before she comes in, you take a minute, you sit down and look at it. The yellow flag questionnaire comes back with a score of 77. If you haven't heard of the yellow flag questionnaire, that is that's a survey. It's a questionnaire that Craig Levinson and a couple other people put together based off of the book World of Hurt. And this yellow flag questionnaire is really, really good at determining how likely is it for the patient to improve. It brings out certain key points and details. Like if this patient scores high, there's a good chance there's some psychosocial aspects to this that's going to prevent her from getting better, even if you do all the right things physically and from the biological perspective or the biomechanical perspective. There's a chance that psychologically and sociologically, there's things that are going to prevent her from getting better. So a score of 77, anything over a 50, I'm always looking at it like, okay, here we go. We're going to have to do a lot of framing with the way we look at our symptoms. We're going to have to do a lot of really making sure we're clear in our discussion with the patient of what exactly is going on with them. We did the back ornament as well. The back and the neck ornament are recommended in Greg Friedman's documentation course. So we use that. Back and neck, not too bad. It's really not, she's not coming in for pain in her back and neck. It's there. It's part of this, it's part of the puzzle for sure. But that's not what's driving her to come into our office. Symptom severity score. You may have known this one already. If you don't, it's the subjective part of the SCAT-5. It is rated out of, I believe it's 22 symptoms, and you rate them from 0 to 6, which means that that you have a total symptom severity score of 122. She's at a 79. She also has 20 out of 22 symptoms that she's dealing with right now. So in other words, she's got some stuff going on. All right, her chief complaints. First is tachycardia at inconsistent moments with inconsistent syncope. Now, this is the verbiage that she wrote during her intake, which means that if she's using those words, she either works in healthcare or she's been to way too many doctors for this stuff or has been dealing with this for way too long. Comes back to that yellow flag questionnaire. What kind of psychosocial stuff are we going to have to keep in mind? Inconsistency with eyes adjusting to light. Now, we may view that as just light sensitivity, but for someone to put that as one of their chief complaints, that's something that I want to dig a little bit deeper into. Inconsistent reaction to water and food, frequent or severely decreased urination and defecation. So in other words, she's either not peeing at all, or she drinks a little bit of water and has to pee right away. That's weird, right? That's not supposed to happen. Sleep. She's getting insomnia. She's getting nightmares. She's getting heart flare-ups in the middle of the night, according to her Apple Watch. So this patient has been great because she got an Apple Watch to track her pulse, and she started getting a ton of really good data, which I'm going to show you later, because she just started texting me images, and it's really, really cool to see. I mean, from a clinical perspective, it's cool to be able to see when the actual issue is instead of just going off of, hey, it spikes during the night, but we can see how often, how high, and is there any sort of pattern to it. And then she also has memory and concentration issues. So let's go into what she describes in her history. This is all part of our intake form, and this is all stuff in her words. She currently sees a cardiologist for tachycardia and orthostatic hypotension. Currently on 2 medications through the cardiologist, metoprolol and midodrine. Have been on these 2 medicines for close to 2 years now, and they help, but not consistently. The metoprolol helps most with my heart racing in the middle of the night. Cool, okay, so she's got something that helps manage that, because I mean, I don't know if you've ever slept before, but waking up with your heart racing, that can be kind of scary. That's only happened to me a couple times when I was camping at a high altitude here in Colorado, and I woke up having trouble breathing, my pulse racing. I'm like, what the hell is this? And then I like nerd out on it. I'm like, oh my God, this is cool. And then I think again, I'm like, oh, all right. I need to do something about this. Otherwise, this might create issues long-term. All right, so she's currently pursuing care for anxiety and depression. Keep that in mind. There's anxiety and depression with the psychiatrist. Using Prestique helps with the depression and anxiety. Since starting that, she had a substantial decrease in her symptoms. 2 weeks on it, she was able to run 1.5 miles in the heat of the day without syncope for the first time in 7 years. So what does that mean? That means a medication for a psychiatric medication for anxiety and depression helped with her POTS. Does that mean that the POTS is psychogenic? No. But what it does mean is that a similar brain system, a similar loop, or potentially the same loop, may be creating two effects. They also prescribe hydroxyzine to help with her panic attacks and nightmares. I have some PTSD that is triggering my general anxiety. I decided to really pursue care here just in case it was a factor. The hydroxyzine does not seem to have an effect on my symptoms at all. However, it does put me to sleep, so she's not going days without sleep. All right, so we know that insomnia may be associated with the same systems, but her medication is helping it. If you don't know what all these classes of drugs are, I'm not going through this because it's not within my scope to be able to do this in a continuing education setting. But you should get on Hippocrates and you should read up on each one of those. And if you don't remember what that is, ask Dr. Riggin for his clinical pharmacology notes that we got at Western States. It breaks it down super easy into classes of drugs, so that way you're able to know exactly what goes on. Sorry, Dr. Riggin, I just volunteered you. I'll make it up to you. All right, so first symptom, which is tachycardia at inconsistent moments with inconsistent syncope. Which says 9 out of 10, 80% of the day, she experiences it in some way. So she was diagnosed with POTS in 2017. It is now 2021, 4 years. She can remember having these symptoms as infrequently as early as 10 years old, but on a weekly basis since she was 16. She pursued treatment initially because she thought that she was falling and having memory issues. Okay, so fall risk, balance, brain. Balance isn't always physical. Balance is your perception of where you are in space and where you are in relation to gravity. If you remember from our previous talks, that is a vestibular system, that is a proprioceptive system, and they integrate in the brainstem so that we get the same message coming together so you can provide an excellent, a quick response to changes. The heart rate bit of it was something I suppressed due to my mother's traumatic account with her cardiologist. So she's already volunteering information that probably she wouldn't otherwise. So that's one of the reasons why we do our 30-minute complimentary phone calls, is to create that doctor-patient relationship before they even fill out their paperwork. So that way there's some sort of level of trust. I'm grateful that she was willing to say, hey, just so you know, I've been getting this heart rate stuff for a while, and it's stuff that I've even hidden from other doctors because I'm afraid of judgment and afraid of other people's experiences other people have had it with doctors. We have to remember from a customer service perspective that we don't know what their prior experience was, and we need to make sure that we're doing whatever we can to create a comfortable, trusting environment for patients, especially when she's like fainting while falling asleep. Not exactly, but like that's the gist. First cardiologist scheduled an echogram, an EKG, and a tilt table test. There were slight abnormalities. The short EKGs generally came up normal unless she's in a flare-up. They did not allow her to fully pass out on the tilt table test. In other words, they stopped her before she passed out. When I do a tilt table test, I kind of just do it just because if we want data, we get good data. And if she's going to pass out there, we at least have her in a safe situation where we can manage that. We don't want to stop and skew our data because then we don't have something to compare pre and post to. They had enough of a spike in the heart rate to diagnose her with POTS. And without any follow-up in mind, the doctor prescribed fast food once a day to increase the salt intake. So Let's hold judgment for now, but that's got to be one of the funniest recommendations I've ever heard another doctor recommending. A month later, after passing out during a haircut, she decided to get another appointment. He again told her to increase salt intake with no follow-up. Frustrated, she pursued care elsewhere. My second cardiologist is the one I'm seeing now and has been seeing since 2017. She initially put me on Bystolic, 1/3 of the pill, and my body seemed to hyperreact. And I can hardly function due to my heart rate being too low. Next up was metoprolol, and I am still on that today. I respond fairly well to it. However, it does not seem to work as well or as long any longer. So what does that mean? The mechanism of action in the brain is having some sort of upregulation or downregulation that's preventing the efficacy from maintaining the same rate as before. She started off on 6.25 milligrams a day and quickly increased to 100 milligrams within a year and a half. When the tachycardia couldn't seem to settle down and we had increased the metoprolol, I started passing out with different symptoms, and we found out I also suffer from orthostatic hypotension. So typically people think of those as opposites. POTS is pulse racing, orthostatic hypotension is blood pressure dropping. Simply people think of those as opposites, and I've had discussions with other doctors where they think of them as opposites, but that's not an appropriate way to think of it. They are two completely different mechanisms in the brain. They just look different as well. But they look like two ends of a spectrum, but they're different mechanisms. Okay, they put me on Midodrine to offset the metoprolol, just to keep that tachycardia under control. I'm getting really impressed with myself, not stumbling over all these medications, but on the back. All right, there has been multiple Holter monitors and a 2-week monitor ran, but frustrating enough, it wasn't enough to raise concerns. In other words, unless they catch her in an episode, they think she's normal, which means maybe they're not doing a deep enough exam to find the problem. They're waiting for the problem to come to them. When you wait for the problem to come to them, that means you're waiting for the average problem to get worse enough that the quality of life is severely diminished. We don't do that here. Second symptom, just recently, my eyes have struggled to adapt to light. I can't see a movie in the theater during the day and walk out to sunlight, or else I will be unable to open my eyes. If my eyes get this way, then I get a really intense headache. So light sensitivity creating head/face pain. And that's a 3 out of 10, 20% of the day. Third symptom, 8 out of 10, 100% of the time. This is constantly happening with her. Urination, defecation issues. Issues keeping water in, and generally have to have some sort of electrolyte solution. A lot of times I will drink fluids and within 90 seconds have to urinate. It causes issues throughout my day and I end up dehydrating quite easily. I struggle with food intake as well. I will inconsistently get sick, either nausea, vomiting, or diarrhea. There does not seem to be food triggers nor time of day triggers, but it does seem to be consistent with days my heart rate is inconsistent. I have massive fluctuations in my weight due to trying to avoid food completely on days when my stomach is not happy. I am fairly consistently nauseous throughout most days. This also affects social life. I would say that I'm nauseous for at least half a day every week. Also not pregnant. That was good. So she's been to doctors before who have asked these questions. So she knows, so she's like already giving me all the info that I need to know. Fourth symptom. Before we think about that, think about urination defecation. What nuclei so we can think of it physically. Is it because there's some sort of inflammatory space occupying lesion in the pelvis, whether the space occupying lesion is a fetus or the space occupying lesion is some sort of neoplasm? We need to start thinking about that. However, that was all stuff that was looked into already by other doctors. I'm not going to go down another rabbit hole and repeat the same tests if she just had them recently done. Now we think functionally. If we don't think that it's a space occupying lesion that's creating some sort of pressure, so that way when she intakes some food, or some sort of inflammatory bowel syndrome where she eats the wrong food, creates inflammation, bloating her, and then putting pressure on the bladder, causing urination, maybe it's just a regulation issue neurologically. So that's a sympathetic, parasympathetic balance. through Onuf's nucleus in the bottom of the spinal cord, and through another nucleus in the lower brainstem. So when we're trying to work our way through this, we're like, okay, excessive urination usually is sympathetic. Excessive defecation usually is parasympathetic. So if she's having issues with it, where she's peeing all the time when she drinks, but then she's constipated, that means that she's resorbing a ton of water. Because remember, the crypts in the colon, that's all about water resorption. That means to me, okay, maybe she's got something going on where the regulation in the autonomic system is just not being modulated appropriately, and it's causing sympathetic overdrive in one direction and parasympathetic underdrive in the other direction, creating this balance of symptoms. It's the only thing I can think of that would tie these two together before doing an exam. Fourth symptom, sleep is a major issue. I've had severe issues with my sleep ever since I was 13 and have been on sleep medications fairly consistently since I was 15 or 16 years old. My family tells a few stories of my sleepwalking. That is consistent with stress and my nightmares. Earliest time with either of these, I remember being around 6 or 7. I've dealt with the sleepwalking fairly consistently for years. I saw a sleep therapist diagnosed with light sleep apnea. Remember that? They had to megadose me with Ambien so I can even get to sleep. And they said I would have to get another test to confirm. But since my insurance was willing to pay for a machine, I should take advantage. I really did try, but I would take the mask off in my sleep every night. So I really, truly don't know if there's any change there. So before we get more in here, just everybody know that the tests they do for sleep apnea, there's a couple different tests, but the majority of the tests that the pulmonology world does when they do it is they put a bunch of electrodes on your brain and they measure respiration rate while sleeping. And if your respiration rate is below a certain threshold for your age group, then they say you have sleep apnea. What does this mean? This means that if you are below a certain threshold, then insurance will pay for the treatment. If insurance doesn't pay for the treatment, then they're like, nah, whatever, we can't sell you anything. So got nothing for you. But remember, it's a test based off of respiration rate, the amount of breaths that you have per minute. I have issues with insomnia, staying asleep, nightmares, sleepwalking. I think about this, I think a lot of this might be psychological. So she even thinks it's psychological herself. She's already in her own head thinking that this is psychogenic. I bought my first Apple Watch in 2018 to monitor my heart during sleep because I assumed the nightmares and crappy sleep was associated. Without the metoprolol, my heart rate will sit above 120s, but my resting heart rate is generally low 50s. So she normally is in pretty good shape. She's a personal trainer. She's a dancer and a personal trainer. Her resting heart rate is low 50s usually. But without this drug, her heart rate will sit in the 120s while she's sleeping or trying to sleep. She can go days without sleeping, but her body does not respond well to it. Not a surprise. If I'm having a really rough few weeks with sleep, the way I come out of it every time is sleeping with an absurdly amount of sleep in one bit. It is usually anywhere from 15 to 50 hours straight. I am pursuing psychiatry care to help with the nightmares. Since starting the metoprolol right before bed, the heart rate spiking has subsided about 75%. However, sleep is still so horrible. And last, memory and concentration issues. I pursued care from a neuropsychiatrist to see if I had any cognitive damage. Until about 21 years old, this was in 2015, I had a really sharp memory. It started declining fast, and it was terribly scary. I pursued care when I forgot where I lived. I did not know who to call them. I sat in a parking lot and had to get my body and mind to calm down before remembering, and I was about an hour and a half away. In order to be a credible and valid personal trainer, I have to have every workout planned on the spot and then lists of exercises to adapt to, because if I'm put on the spot, I can't guarantee I will remember any exercise associated with what we were doing. Makes my work hard, and my work is something I love. So she's struggling. She can't do the job that she loves doing. She's having trouble doing the job to begin with. And with her personality, she can totally fudge things along so people still have an enjoyable experience. But I mean, she has some integrity in her job. She has some expectations for herself, and we got to respect that. And we got to say, how do we get her back there? So now we're seeing something that looks like cognitive decline at 21. So what should we be looking for if it's a cognitive decline case? Because we're already talking about a couple of different things. We're talking about a POTS case. We're talking about dysautonomia. We're talking about a anxiety and depression case. We're talking about some sort of psychological issues. We're talking about cognitive decline, which she's viewing through a neuropsychiatric lens. There's so many different blends of brain or the mental health world that's getting looped into this. But where do they all intersect? Where's the smoking gun? The answer is there's usually no smoking gun. It usually is a couple of different areas of intersection and loops that loop on themselves that all of them branch out, and it gets a little complicated, but we're going to break them down for you. How many lifetime concussions? I pass out about 2 to 3 times per week due to POTS. I'm not sure how many times that has resulted in anything major. So when I asked her about it, she said, coming later, I asked her about it. She's like, okay, well, when I pass out, usually I catch me like that. I pass out and I usually wait, get back up, or I usually come back to before I hit the ground. So if she passes out, she usually just kind of falls down to a knee, and she's usually okay, but sometimes they're a little worse. So every patient that we do built right into our intake form uses something called the brain region localization form. This is a form that you can get by taking module 2 of functional neurology seminars through Brandon Brock and Atis Karazian. I think it's a great form just to have because you can get some real basic information. You can try and correlate to what areas may be struggling. So the way I did this analysis is these are all the sections on the left side with the associated Broca's areas. In the middle is her score, and I took an average of it based off of the number of questions in that section. So there's a little bit of a bias when you have, and so there's a little bit of bias when you have something like the temporal lobe auditory association cortex, Broca's area 22. I'm sorry, Brodmann map area 22. There's only 2 questions in there, so of course it's going to have a high percentage. So we got to take the little bit of a grain of salt. So give me 1 second. Now, we've got frontal lobe, prefrontal cortex, dorsolateral prefrontal cortex, and orbital frontal cortex. Brodmann map areas 9, 10, 11, and 12. She's scoring like a 76%. And there's a lot of questions for that. So she's got a lot of stuff going on in that area. Frontal lobe, supplementary motor area. For some reason, I'm brain farting on the PC. 29%. Not too much going on there, but areas 4 and 6. So we're talking about not the front of the brain, we're talking about the areas more in the back brain. Remember, 3, 1, and 2 is sensory. 4 is your primary motor cortex, and then 6 is your supplementary motor area. I guess that's PC is primary cortex. Then areas 44 and 45 is Broca's motor area, and she's struggling with speaking, just getting words out, according to her, subjective. So your primary somatosensory cortex and your superior parietal lobe, 3, 1, 2, and 7. She's got an 85%. Inferior parietal lobe is 43, not too bad. So superior parietal lobe also has to do with vivid memory. Like if you ask somebody to describe a situation, they may tell you the story, or they may just say, here's the details. If they tell the story when there's a lot of descriptors, usually that means that their superior parietal lobe is doing pretty well. if they have trouble, or they're super bland in the story that they're telling, and you're like falling asleep halfway through, but it's not because they're going on and on, but they're just like not describing it in a way that's like really like, they're not describing it in a way that you can like really like latch onto and envision in your mind. Usually that means that the superior parietal lobe might be having some mapping issues. Okay, auditory cortex isn't too bad. Associative auditory cortex isn't too bad. Medial temporal lobe, and so it's in the temporal lobe, the medial temporal lobe, and it is about 75%, but there's a lot of questions in there, so she's probably hitting a bunch of those. Occipital lobe is totally fine. So she had visual issues with light sensitivity, but none of them were coming up with the actual occipital lobe. Now her cerebellum, her vestibulocerebellum, so the spinocerebellum, cerebrocerebellum, and the vestibulocerebellum. The spinal cerebellum is fine. The first two are fine. The vestibulocerebellum is the one that seems to be getting a lot of the issues. So that's the most lateral aspect of the cerebellum. Think of it as like fine motor control for hands and feet. Remember, cerebellum is for coordination, balance, coordination and balance of motor movement, but it's also coordination and balance of thought. Remember that thought is a motor pathway that just stays inside the brain, shunts to your frontal lobe, through your thalamus, and then interplays with the thalamus to create a conscious experience. That's thought. Okay, basal ganglia. Her direct pathway is firing a little bit higher than her indirect pathway, or is having a few more issues in her indirect pathway. So then her parasympathetic is fine, but her sympathetic, she just went straight up 100%. All right, so we're thinking, yeah, okay, so she's just in super hyper sympathetic drive. From what? Who cares? Because you can never tell a person to just reduce the stress in your life. In reality, the amount of stress that you perceive in your life isn't necessarily all environmental. It's also how well your brain can handle and cope with the stimulus that is put on it. If you have a stressful situation and you can't remove that, if you improve your brain, that stressful situation now becomes less stressful because you're like, you know what, now my brain can actually handle this amount of input and complexity of thought. So what are we looking at here? She's got a bunch of different areas that are involved. She's got her frontal lobe that's really failing. She's got her cerebellum that seems to not be regulating well, and she's got her sympathetics that are just driving off the hook. So 2 days before the exam is on the left, and the day after the exam is on the right. Okay, so let's think about this. So on the left, walking, her pulse spiked to 150. I don't know about you. I mean, I just stayed sedentary for 2 years, or no, what feels like 2 years with COVID. I still don't think that walking will make my pulse spike even with that much deconditioning. There's something that's weird. And it spiked again a couple of times. You can see that it spiked right after lunch, and you can see that it spiked around, we'll call that, I don't know, like 9 o'clock at night too. And then the day after, so during my exam, we do a little bit of treatment, just enough to figure out and make sure that the home exercise program that I give works and doesn't mess them up further. Because you can, when you talk about brain rehab, you see changes right away, and you can see if you're making the patient worse right away. There's no like, oh, don't worry, you just gotta let your nervous system settle. No, that doesn't happen. You either go in the right direction or the wrong direction, and it's nice because you get to say, "Ooh, let me fix that." All right. So on Saturday, the day after the exam, and we have a 2-hour exam, it's relatively provocative in the way where it's stressful on the body because we're testing everything. She had a bunch of spikes that reached over 120, but she was spiking over 120 with no actual activity. So she's doing okay, but she's not where we want her to be. I mean, let's be honest, she's not really doing okay. Look at all those spikes that she had. She had a perspective. From this perspective, she's in a position where she's spiking throughout the day and she's just like walking around. She's not doing any exercise. She's got like 10,000 steps, but that's probably just from walking around. All right. So she's now in here. We just went over all that stuff. That's the thought process going through my head already of all the things that we discussed so far. So then we have our mental status testing. So what I do is 3 words: dog, share sign, or blue hat fish, whatever I'm feeling like that day. And I want to see, can they remember it? Can they say it? And then can they remember it a minute later? And can they remember it 5 minutes later? Yeah, she can do that, no problem. Serial sevens, counting back from 7 by, counting back from 100 by sevens, not a problem. Spelling world, typically when you have them spell it backwards, they forget R. She was fine. Monotone digit span. So I would say, okay, I want you to repeat, I'm gonna give you 7 numbers. I want you to repeat them back to me. 2, 9, 4, 3, 8, 6, 3. Digit span was fine. She missed 3 of those numbers. Then when I said something prosodic or melodic, then I would say 3, 9, 4, 7, 2, 5, 8. Totally fine. So we know that there's something going on with her temporal lobe and the memory cortex that has to do with patterns and recognition of patterns from auditory speech. Okay. So now we're jumping into the physical exam. We're going to go through parts of it, and then we're going to take we'll take like a 5-10 minute break. All right, so vitals. We do bilateral blood pressure in the office. We get the Omron Series 10, we put them on both arms at the same time. I say, hey, we're gonna take your blood pressure. Just so you know, talking can change blood pressure up to 10 points. So we're both just gonna hang out and chill. If I'm feeling extra talkative that day, sometimes I'll make a joke and be like, I try not to do the dentist thing where I ask you questions while I'm working in your mouth. So we're gonna do the same thing. Let's not talk, both of us. And then I get to not talk for like a minute. It's great. So seated blood pressure, 154/95 on the left with a pulse of 55, 150/95 on the right with a pulse of 55. Check the pulses. Pulses should be the same or within 1 point to make sure that you're getting clinically accurate data. Seated SpO2. So the partial seated seated SpO2, you're measuring the amount of oxygen in your finger. Perfusion index is a pulsatile measurement of it. We're going to talk about that later. 95% bilaterally, 2.5 on the left, 2.8 on the right. Standing blood pressure. So the way we do it is we just go straight from sitting to standing and we measure it again. We're not waiting the typical minute that you're supposed to do for true orthostatic blood pressure, because we want to see how does she respond functionally. She's not going to faint after standing for a minute. She's going to faint if she stands up too quickly, right? So we want to see what's happening with that. So standing blood pressure on the left is 159/117. On the right, it's 158/116. Pulse is 64 both sides, so you know that there's some clinical accuracy of the data. SpO2 and perfusion index, 95% on both sides. Now it's 13.5 on the left and 0.8 on the right. 0.8 is almost so low that it's not even, that it would invalidate the 95%. If it gets to 0.4, that invalidates any SpO2 that you have. So because that means there's not even enough oxygen going in there to say that when you're measuring the amount of oxygen attached to hemoglobin in the finger, that could even be accurate. So what the heck just happened there? Well, we gotta puzzle this together. Okay, now we're going through the cranial nerve exam. So, no blepharospasticity. What does that mean? When they close their eyes, they're not over clenching, right? You'll see that in kids on the spectrum. You'll see that kids with ADHD focus issues. It usually is seen with people who may have some sort of light sensitivity, but she doesn't have that. She just closes her eyes, she's fine. She has no, what's it called? She has no blepharoclonus either, which is when you close the eyes and it starts like twitching. She doesn't have that either. That's a basal ganglionic thing. One is basal ganglionic. One is a how do I put it? It was like it's a reaction to light sensitivity, but also could be direct path with basal ganglionic. There's no hypomemia. Hypomemia is lack of facial expression. You'll see that in Parkinsonian patients or something with progressive degenerative conditions like Parkinsonisms. No evident facial motor spontaneity. So she doesn't have any twitches. She doesn't have any things that are like just happening on its own. No evident ptosis. That means that both eyelids, neither eye is just like one eyelid isn't drooping. Gaze is conjugate at rest, but there's a slight inferior preponderance. What does that mean? That means that she thinks at rest, with her eyes open, even with visual fixation, she thinks that straight ahead is down. That means that something is pushing her eyes down, or the maps that her brain is building is saying that straight ahead is this way. And the map that his brain is building is maybe saying that, hey, I'm leaning like this. This is standing up straight, when in fact this is. VA ratio, 3:1 on the right, 2:1 on the left. Remember vein to artery ratio? Of the two veins, arteries, which one has smooth muscle in it that allows sympathetic activity to contract it? I'll give you a second. Good, arteries. So in other words, veins should be bigger than arteries, but the smaller the arteries are compared to the veins, the more sympathetic drive you're seeing. And you're seeing more sympathetic drive on the right compared to the left. Fundoscopic exam, you take your ophthalmoscope. I'm going to say if you've had a practice for over 6 months, you should have a panoptic. If you've had a practice for even longer than that, just expense a panoptic. It's like $600 or something like that for a brand new one from Welch Allen. Grab it. It's always good to have one there just in case you need to check something. And there's a ton of data you can get just from looking in the eye from a neurological perspective. And if you're using the thing where you're trying to touch noses with people, it's just poor data. It's just not, it's like, if you're big on x-rays, it's like using the actual old school film x-rays compared to a digital x-ray machine, and then trying to interpret it on a light box versus an actual like digital screen where you can zoom things in and flop colors and all that stuff. Like it's just completely different. Like the amount of technology is so different. You can buy yourself this for your own present this year. All right. Symmetrical facial recruitment when they speak. Cranial nerve 7. Is it symmetrical? Or are you getting like that? They're talking outside their mouth. No aberrant head posture. Do they have a tilt? Do they have a turn? Do they have some sort of rotation of their head? Are they looking at you like when they think they're looking straight ahead at you? Is their nose actually pointing at you, or is their nose pointing away? Wherever that is, that actually is very, very clinically significant for vestibular and proprioceptive findings. And no aberrant posturing itself. Now, you usually think of like antalgic posture as the first thing that you're looking at, but you're also looking at like this clinically represented posturing that you'll see when you're looking at some of these neurological conditions, and also like when you see them walking into the office. But she didn't have any of that. She looked like a normal, healthy person until we started like dissecting everything. All right. Olfactory recognition and perception is normal. In other words, nose works fine, but it's increased on the right. So if you remember from the last time we talked last year, that was a long time ago. If you remember from that, it is increased on the right, which means hyperosmic on the right, which means that at some point, whether it's the prefrontal cortex, orbital frontal cortex, or it's the the parahippocampal gyrus, or is the dorsal motor nucleus of cranial nerve 10 all on the right? Something there is too sensitive. It's on hair triggers, firing too high, right? Now, firing too high is just as clinically significant as a deficit. And we want to make sure that we're noticing too high, not just noticing, is it not working? A right chorectasia. That means that her right pupil is larger than her left pupil. Now, what does that mean? Now, clinically in my note, I always put chorectasia as my first guess. Like which one is bigger compared to the other one? Could it be a left choromyosis? Totally could. But when we looked at the VA ratios, we're starting to see like, hey, there's a little bit of excess sympathetic drive on that right side. So we're pretty comfortable saying it's a right chorectasia. No heterophoria on convergence. What does that mean? Follow in, just does it come off the thumb when you're following it in? No, we're fine. Bilateral accommodation spasm and upward gaze, worse on the left. What does that mean? When I have the person saccading, so they're going from down to up, back and forth. So you see, when you go to the top finger, so the eye should be tracking. Let me get this right, because I don't know why I'm having so much difficulty with this in the camera, but it should be going like this, straight up at the top and coming in like a V at the bottom. Think of it as you're looking from a book that you're reading to a tree in the distance. Goes far away, comes back like this. Also, when it comes down, the pupil should shrink. That's an otolithic response. The measurement of translation through gravity, forward, back, side, up, down, no turning. That is your otolith, your saccule and your utricle. And that's a response you're supposed to have. But when she goes from down to up, she gets a accommodation spasm on the left. She gets them both, but worse on the left. So what does that mean? That can mean a ton of different things, and we're going to go through a couple of them. Sluggish direct pupillary response. In other words, when you shine a light on it, it gets smaller, slower than it should. Sluggish consensual pupillary response, which means that the same thing's happening on both sides. So we can see it's not an issue with the periphery, it's the issue with the integration at the top of the brainstem, probably something's going on with the midbrain and spilling over the Edgar-Westphal nucleus. Horizontal pursuits were fine. Vertical pursuits were fine. Horizontal saccades were fine. Vertical saccades were fine. In other words, they were normal. And remember, this is a chart note for my medical record system. This was normal for pathological values. Does that mean we didn't find stuff that we need to improve? No, we found stuff to improve. But this is appropriate. And if another doctor read this, we sent them to a neuro-ophthalmologist, or sent them to a PM&R doc, or a neurologist who specializes in posturitis autonomia, they're going to be able to read this and be like, okay, they would agree with what we saw. Anti-saccades, no pro-saccadic error. So when we say, okay, look at the thumb, I'm going to wiggle a thumb. Keep your eyes on my nose. I'm going to wiggle a thumb. Don't look at it. They say on the thumb, that's a pro-saccadic error would be ooh, shiny thing. Optokinetic testing yields adverse response, worse to the right and worse in the vertical plane, worst downwards. So an adverse optokinetic response means that we need to now throw her in some goggles, which you do anyway, just because it's good data. But when you have an optokinetic, that's when you take a background and you have a background move. So if I use an example of an optokinetic, and I have you looking at something like this, the world is moving in one direction. Your eyes are supposed to drag with it and snap back. That's an optokinetic response. Drag, snap, drag, snap. It's a balance between cerebellar, parietal, and frontal lobe processes. And we want to make sure that all three areas are working well. She had an adverse response. In other words, it wasn't just sluggish or diminished. It was like painful for her to have that, which means when she moves through gravity and the world moves around her, her eyes are not reflexing appropriately. So her brain thinks that every time the world moves around her, she might be moving. Sometimes that can cause dizziness. Sometimes that can cause nausea. Sometimes that can cause like vertigo or malabargement or lightheadedness. But sometimes it can also cause deregulation in the brainstem because you think you're going from sitting to standing, your brain starts firing reflexes because your brain thought you went like this without the baroreceptor activation, and it's trying to predict that because it usually it'll tie the two together and say, okay, well, when I go like this, I should feel this and I should do that. It's not feeling it, and so it's over responding in an inappropriate way, pulse jumping when it shouldn't be jumping. But if we, again, horizontal and vertical ontogonetics were intact and symmetrical, which means that she had an adverse response, even though that they were not as, like they were clinically normal, pathologically normal, and within normal limits, but still there was enough in there that we're like, oh, there's something going on here. All right, we're gonna take our first break and we're gonna break for 10 minutes.
Okay, Mike, I'm going to go ahead and pause the recording, and when you're ready to come back, I'll resume.
Okay, so we're picking up where we left off on the wrist deep in a cranial nerve exam. So we have no sensory asymmetry with pinwheel testing on the face, vibration sense decreased on the right, but it's intact bilaterally. Light touch is symmetrical and intact bilaterally. So if you're doing a neuro screen with patients who have had concussion or have some sort of neurological stuff going on, your neuro screen is essentially muscle testing, sensory testing, and maybe shining a light in their eye or doing like a quick cranial nerve stuff. Just know that you're probably missing a lot of data, and it's probably not appropriate with what we know in this day and age with what we're able to determine with neuroscience. I would definitely, if there's something going on with the brain when it comes to POTS or concussion or just anything degenerative, neurodevelopmental, you've got some people in the area that you can always refer to or reach out to, or you can even like contact me and just go through the case with me, and I can tell you what stuff that I would test. Like last year, we went over things like which cranial nerves would you do for this scenario, based on what the presentation was. So we just want to make sure that you're not missing data, because we want you to come across as the hero, not as the I don't know. All right. There's no sensory asymmetry in facial region, symmetrical muscle tone and muscle domestication, normal corneal reflex, so poke your eyes. Weber test lateralizes to the left. What is Weber test? You take a tuning fork. 512 is usually most accurate. 512 is classically how the test is done. I do it with that and a 128, just to make sure and just to see what the vibration does. Because if you take a 128 hertz and they don't feel it on both sides, then there's something going on. So I take a 128, I throw it right up here, or if that's weird, I throw it over here. And if I do both and they say opposite sides, I usually go with the top over this. But if I go with it, put it on the top, I say, okay, which side do you hear it more on? And it lateralizes to the left, which means there's some sort of deficit on the right side. And since vestibular information and the cochlear nerve, so the vestibulocochlear nerve and the cerebellar information all sit on that right side together, then we can, if we correlate it to cerebellar and we can correlate it to vestibular and we can correlate it to auditory all on the same side, then we know that there's something going on where this stuff all comes into the brainstem, the lower pons. Rene test yields air conduction equal to bone conduction on the left, diminished bone conduction on the right with normal air conduction. So when I took the tuning fork and I put it here to say, okay, well, how's the bone conduction doing? It was a lot quicker to diminish than on this side. And then you can hold it into the ear and she's like, yeah, no, it's still going. So generally, the way I look at that is, again, something going on with the software here, because you can hear it, but it just goes away quick. So maybe it's a fatiguing system. We'll talk about fatiguing systems. Slight palatal paresis on the right. So you open your mouth, shine a light in, and if you're not looking at the uvula, you're not looking at the soft palate, you're looking at the levator veli palatini muscle behind it, pouching first and then lifting up. So slight parallel paresis on the right probably means it's going like, which means what? Now that I know that there's people listening, I'm going to try and make it more interactive. What it means is there's probably something going on with cranial nerve 10, vagus nerve. No tongue deviation. So what I usually start off doing is to say, okay, stick your tongue out like this. And you'll see like the middle of the tongue is slightly off side to side. That's some, and I'll say slight deviation of the tongue to the left or to the right. Then I'll have them stick it out all the way. Make sure they can do all the within all the limit stuff, but I want them to see functionally. So they stick it out right away, like what? And does that correlate? Okay, peripheral nerve exam. Everything was fine. So if you just did a peripheral nerve exam for this patient thinking it's a neuro screen, you're missing all the cranial nerve stuff. Her reflexes were fine. I was expecting hyperreflexia at some point, but she was fine. The only thing that came up was a positive Babinski on the right. What creates a positive Babinski? All of your primitive reflexes, they all go away at whatever age they go away because your frontal lobe develops enough to bring it under control, which means that if you have a positive Babinski at 18 months or 17 months, that's fine. If you have a positive Babinski beyond 18 months, that means that the frontal lobe didn't develop enough on whichever side is opposite that Babinski. So positive Babinski on the right means that something's going on with her left frontal lobe that has lost that control if she ever had it. No sensory asymmetry with pinwheel testing in upper and lower extremities, joint position, sense and check, vibration, light touch, totally fine. Coordination, station, and gait. Slight dysdiadochokinesia with rapid pronation supination at the shoulder and elbow joints. Worst with fatigue, but improved again when we brought the elbows in. What does that mean? When it's out here, you're using a lot more cerebellar input to balance your body out and trunk support so you don't tip forward. When you bring your elbows in, it's more just of a parietal frontal lobe reflex of can you get from here to here as fast as you can and keep it going. So if it's worse on the left both times, but it got better coming in, so we're thinking there may be something going on with pronation supination with the left cerebellum. And then it gets better here. So the right parietal lobe is firing a little bit better than the left cerebellum, than the left cerebellum for that activity. Pincer test was fine. So just like throw a piece of paper in there. Can you hold on to it and go? Finger tapping. Remember, finger tapping is there's 3 rules. Watch me do it first, as big as you can, as fast as you can, 10 times. And then I say, all right, now you do it. I always do it with my right hand because my left hand shows some stuff. I don't want to distract them. Finger to nose testing was accurate. Heel to shin testing was accurate. Now I did a Romberg test. If you have an AirX pad, Romberg test would be a great quick thing for you to include with any sort of these neuro cases. What Romberg test clinically and classically is, you have them stand probably in the corner with their feet together, have them close their eyes, and then if they fall to the ground, it is a dorsal column system issue. Now, if they close their eyes and they're jerky as they fall to the ground, that's usually, I mean, this is a cerebellar issue where the dorsal columns fired the cerebellum, remember like Clark's nucleus and all that stuff. Now, was it nucleus Z? I think that's in there too. Now, if you throw them on a foam pad and they can balance, but you look at the directionality of sway, you can see what areas, did we just lose my screen share? No, I think we're good. Did we lose the recording?
It seems to be still running.
Since we're still running? Okay, cool. So when you put them on, when you're testing Romberg test, what you're trying to do is you're trying to associate certain biases for different parts of the neurological system, or the neuraxis, as some people will refer to it as, and say, okay, if we isolate this one thing a little more, or bias this one thing a little more, how steady can you be? So, so we start off with a head straight ahead, close your eyes, see what happens. Then we go, I always go left first, close, and then see how well they balance. Right first, close, see how well they balance. So in other words, when we did right cervical rotation, that got better. Then I say, okay, left, and we tilt that back. Then we tilt that forward. So we're doing left posterior canal, right anterior canal. I do the same thing on these sides. And then we do chin tucked, which reduces information into the vestibular system and stabilizes a little more. And then we do neck extended, which creates more information, more input to the vestibular system. And we say, okay, what happens if we just like increase information everywhere? She was she was pretty bad. She had moderate instability with everything, except it was better with right cervical rotation and left anterior canal. So with the head turned to the right and head going forward, we had better improvement. No change in stability with postural challenges. So that's when you had on the foam band, you kind of push them around a little, make sure that they can stand up and react to it. And then when I did a gait test, decreased left arm swing with gait testing, the left cantilever swing produced with cognitive dual tasking. So when you look at gait testing from a neurological perspective, what you're trying to see is asymmetry. Which side is swinging less? Because you know, arm swinging while you walk is an efficiency mechanism that helps create and save energy so that we continuously, you can walk longer. It's why humans have evolved to be able to chase down prey that's much faster than them by just staying with them longer over time and continuously hunting. So when we're looking at this, we're saying, okay, well, the left arm swing is decreased when we start looking at it, and then we're like, wait a second, that's not a loss of left arm swing. That's a perception of falling to the right. So the left arm swing is now out to the side, just enough to create balance, but it's still at a subconscious level. So what does this mean? This means that, hey, there's some so there's either a deficit on the right side proprioceptively because she's falling that way, or there's a deficit in the vestibular system on that right side because she's falling that way. Or there is on the opposite side, there is excessive activation or escape of the vestibular system because the right side isn't inhibiting it. Or, right, we can go on and on. If there's a visual component too, and her eyes are getting like we already tried that out to kinetic, so we already know that in some directions that her eyes are worse, and she doesn't have that VOR, which means that every time her head moves, she might have like some sort of imperceivable perceptive. She might have this perception that her body is shifting when it's not, so she's going to react by shifting opposite to it to balance out. Does that make sense? Okay. Did I lose anybody there? So physically, we're seeing a bunch of things popping up, and we can see that the left cantilever happens. Okay, so video oculography. Basically, for notes, I just put like if there was a spontaneous nystagmus, and she had a mild right beat nystagmus in a bunch of different ways, and then she had a bilateral accommodation side and worse on the left. Let's watch the video though. Okay, this is her. Okay, first thing we're looking at. Which pupil is bigger? The one on the right. Second thing we're looking at, does it look like that left eye is a little fuzzier? Yeah, she's sweating on that left side more than her right side. Another thing to look at, are her eyes looking straight ahead? No, they're looking down. The easiest way to tell is the reflection of the camera. The camera should be directly in the center. Her eyes are looking down. This is where she thinks straight ahead is down. And it also looks like that right eye is a little bit out to the right, which means it looks like her eyes preponderance are down and to the right. But this is me just saying, stay looking straight ahead. Now you may notice some, I'm going to rewind a little bit. Oops. So I'm having her look straight ahead or where she thinks straight ahead is. Now you may notice that her eyes continuously drift to the left and then have that fast phase going to the right. It's tiny. She may go to PM&R and they'll be like, oh no, that's totally fine. But that's clinically significant enough that it can create symptoms. So that's something that we're looking at. Okay. So now what I have her doing is look to the left and hold it there. Notice she doesn't even get all the way to the left. It stops. Have her look to the right. She doesn't get all the way to the right either. It stops. Her worldview is so small right now. Her brain doesn't know that there's more world around her to the sides. I have her going back and forth a couple times just to see if repetition will improve it. And it does. It gets a little bit better going over the left and going over the right. Now she's getting there. And I have her look down. I have her look up. Check that out. How cool was that? I'm going to rewind it. I have her look down. So what does that mean? Remember we talked about how the eyes are supposed to go straight up and they should not get small. They should get small when they come down. When she looks up, her eyes slam together. She has that accommodation reflex. In other words, every time that she looks up, she thinks that she's falling forward. She thinks that she's looking at the book right here, except the book's up here, which is not an appropriate reflex whatsoever when you are putting goggles out of a dark field and you can't see anything. So what does this mean? This means a couple of different things. It could either be subjective visual vertical if they all both go in the same direction, where she thinks up is actually on an axis like this and up is that way. I've seen that in a number of patients. This is not what we're looking at. What we're looking at is an accommodation spasm bilaterally, worse on that left side, which means that she has a mapping issue of where she is in space. And it also means that she thinks that when she looks up, she's falling forward. Where if you put your body in a position where looking up is falling forward, that's forward like this, right? So if you're leaning forward, that means that your body must think that your balance point, your center of pressure, which is not your center of mass. When you stand up, your center of mass is between your feet. Your center of pressure is what the center of mass would be if your body was in the position that is actually mapping you out as. Does that make sense? Is everybody with me? In other words, even though I'm standing up straight looking in the mirror and I'm symmetrical and my posture is good, if my brain has my posture mapped as leaning backwards, it is going to automatically be firing reflexes to push me forward, right? Because it's going to say, when your center of mass does not match up with your center of pressure, oh, I must be falling backwards. Something isn't right here. Let me fire something. And now you're getting a reflex to fix a problem as a compensation to a problem that shouldn't be there in the first place. And her brain is taking the brunt of the force from that because she has to now figure out, or her brain has to figure out what's real. So see, it comes back to normal, nice and big. Again, looking down a little bit. So in other words, she's already looking down. She already is sitting like this. So that means when I had her look up, excuse me, I gotta sneeze. So when she already thinks that this is straight ahead, which means if you actually match it to real straight ahead, she's leaning back, which means that if she looks up and thinks she's falling forward, there is a disconnect there. Okay. And now you see that right beat nystagmus got worse. There it is again. Now I'm doing a repeat vertical saccades. I'm like, okay, well, maybe it's just a one-time thing. I'm gonna have her look back and forth a couple times, see what happens. I do this for two reasons. First reason is because the guy that I learned from did it. Three reasons. Second reason is because I'm trying to see with repeat vertical saccades what we're looking at. And the third reason is for the next test, which is just looking straight ahead again. If we disorient them, what do their eyes do? Can they still figure it out? How well can they cope? And that right beat nystagmus is still there. And you look and you see the camera is actually a little bit even, the camera reflection is even higher now. And so she clearly, it disoriented her. And then she thought, then she started falling back even more. If you're falling backwards, what do you think your pulse is going to do? If you're falling backwards, what do you think your blood pressure is going to do? What do you think your brain is expecting the receptors in your carotid arteries? What do you think your brain is expecting to happen if it thinks you're about to fall backwards? It's responding in a way that's not accurate. So then I have them close their eyes. And then we're going to start doing some VOR testing, where I just turn their head first to the left and then to the right. So remember with VOR, if you have their head and you turn them to the right, their eyes should be dragging to the left and snapping back in the direction of the turn, right? So if I turn them head to the left, which I always start with, and their eyes drag to the right, that means that there is something going on where the refixation saccade, her frontal lobe, is not firing appropriately. There we go. That was to the right. So in other words, her VOR to the right is better than her VOR to the left. Now you can see there should be up and down ones. Her anterior posterior canals just aren't keeping up. They're just not, they're just like saying, we'll give it a little like, but that's about it. That's all you get. And then people start constricting, she gets disoriented, doesn't know what's going on, her symptoms flare up. And that's why we do provocative testing, because we want to see what causes the symptoms. But we're also ready to get her out of that flare up when she gets that. Have you noticed how the eyes are drooping now? Bilateral ptosis, maybe? No, we just hit a fatigue point big time. Neurological fatigue. That means if we do anything more, it's just going to be counterproductive, and it's not really, we're not really seeing anything else. Okay. Any questions about the goggles? All right, so we're about to move on to more fundamental concepts that we need to understand in order to put this case together. We're going to start revisiting old concepts that I talked about the past 2 years. Part of it is understanding what this fatigue point is, what creates the neurological responses that we see. So when you're evaluating any neurological system, you want to keep the following concepts in mind. Time to activation, intensity of activation, accuracy of activation, accuracy of the correction if there's an error, time to fatigue, the magnitude of fatigue. How much do they fatigue when they do fatigue? Do they tank and start getting super symptomatic, or do they just kind of like, We want to measure that. We want to see. And then the refractory period. Is there a period in which you will not be able to elicit a response in the test? Or can you continuously do it? In other words, you're just burning through nutrients. So you get a deficit of nutrients, you're getting a ton of inflammation, and you're trying to and the brain cannot keep up. The activation threshold and resting rate are variable. What this means is, although you will normally hear -55 is a threshold, it's -70 is the resting rate for neurons, it is not, that's average maybe. It is not always that number. Your activation threshold can be lowered based off of the environment that the neuron is in. Your resting membrane can increase based on the environment that it's in. So that activation threshold can be higher or lower with the level of inflammation acting on the neuroimmune complex. If you look at that picture on the right, you'll see that at the purple synapse, you see you have that immune system right there. That immune cell right there with that synapse modulates the synaptic activation to help facilitate or inhibit activation potentials. Normally, inflammation creates more activation. More activation in the brain is not always good. If the neurons cannot handle the amount of activation that you're asking them to do, they will die. They undergo apoptosis, and you need other neurons around it who hopefully are healthier to undergo some sort of, to take over that compensation. What that means is, if you've got a patient coming in with something neurological going on, don't think, hey, let me grab their upper cervical and swing for the fences. Maybe start at the lower in the spine where it's further away and there's less input on the brain. Resting rate become more or less negative with ionic changes. So cells are negative because proteins are negative. The more protein in the cell, the more negative the cell is. The more protein in the cell, the larger the neuron is. In other words, larger neurons are more stable and able to handle more input and activation because they're more negative, which means it takes more energy for them to activate. They're not on a hair trigger. When a neuron is activated, it'll become more efficient. That could be good or bad. So when you create that efficiency in neurons, if it's a pathway that's accurately firing, that's going to be good. You're going to be able to be faster at preventing a fall risk. You're going to be faster at doing cognitive activities. What we're doing from a functional neurological perspective is we're creating the pathway that's appropriate, and we're plasticizing it, which means we're embedding it and we're making it, we start by building the road that connects everything and that we need to be connected. And then we work on it over and over until that road grows with more protein into a superhighway, which means that now if they get another concussion later on, all we got to do is kick on that road. Or again, we don't really need to do like a ton of work. It's just real quick. But if you look at that picture to the right, you can get an increase in efficiency of pathways that are not good. So if she's getting anxiety, what does anxiety mean? It means that cerebellum is firing into the brainstem at a rate higher than it should based on the loops that control it. And if it's firing and then your brainstem fires from its neurotransmitter production areas to the frontal lobe. And now the frontal lobe is getting pinged with neurotransmitters at a rate higher than it can handle. You're going to create that efficiency. But if that efficiency is going to be in a system that feels anxiety, or if that efficiency is in a system where now it's firing too high, the point of which it's firing too high is perceived and presented in the patient's perspective as things moving too fast and anxiety. What happens afterwards? Things move too fast. You push through all their energy systems. And then they undergo apoptosis. They have some sort of you have some sort of degenerative pathway going on, and then you get this spreading wave of depression following it, which is why anxiety, especially anxiety attacks, are followed by depressive episodes. And we're not just talking about I'm sad, we're talking about full body depression. So in other words, if we want to create changes in the brain, we can't just supplement it, because if we supplement it, we're just working on the fuel systems. We're reducing inflammation that's making it fire more, sure. But but you're also improving the energy systems, which is making it fire more. And what if the brain connectivity that was damaged from the inflammation from before, from it firing too much with that apoptotic pathway, what if you start driving that pathway and saying, it's like putting gas into the tank and then stepping on the gas when you got a cracked cylinder. It's just going to create more damage. It's going to look like it's getting better, but then it's going to tank and you're going to see some damage afterwards. So what you want to do is you want to have objective tests and measurements to make sure that when you're creating these pathways and activation in the brain, that you're doing it in a way that's sustainable, not just in a way that's it's not just one level of logic reasoning of brain not working good, I'm going to activate the brain. We need to make sure that the brain is activated sustainably, so that way it doesn't go, yay, good, and then worse. Okay, so we're going to start going through a little more of some things in the cranial nerve exam that we found. So she had a right correctasia. So when you see a correctasia, the first thing that you got to do is you got to look for ptosis. You want to ask about history, what is needed. So I had a patient recently, concussion, had a left ptosis because the right eye, when she was a kid, the right eyelid was surgically retracted up higher. So it looked like she had a left ptosis. In reality, they were functionally symmetrical. Do bedside pupillary reflex. So I use an app called Reflex Pro. I love it. It is great. We use it for every single patient. We use it for follow-ups as well. What we do is you take a picture of the patient's eye and it runs a bunch of metrics on it. And it does a pupillary light reflex with numerical objective data. It's fantastic. Now, we're going to go through some of the things for this patient. So hopefully you'll find it interesting. But when you see anesiochoria, you want to see, is it reduced eye movement? Is it reduced or excessive pupil movement? So either or. Is there fever? Is there eye pain? Is there headache? Is there reduced or increased sweating? Why would we worry about sweating when we're looking at the pupils? Because depending on the size of the pupil and depending on the sweat for that side of the body or the other side of the body, it will let us know where in the brain the issue is or where in the brainstem. If there is a big pupil, which means that's more sympathetic, which means there may be a deficit in the Edinger-Westphal nucleus. It also may mean, or it could mean, that there is escape of the sympathetics coming through the sympathetic trunk, up the plexus, through the ciliary ganglia. So if you see sweating on the same side, so if you see a large pupil and sweating, escape of that sympathetic part, overfiring. If you see a large pupil and dryness on that same side, then what you're thinking is maybe the lesion is just in that Edinger-Westphal nucleus or somewhere in the brainstem. Also, the front of the midbrain versus the back of the midbrain. The front of the midbrain fires through to your intermediate lateral cell column, your IML, which fires up that sympathetic trunk. So if you have a deficit in that anterior midbrain, you may see a lack of sympathetic. Does that make sense? So instead of seeing deficit in Edinger-Westphal, so you have escape of the sympathetic trunk, now you're seeing maybe more functional deficits across one side of the midbrain a little bit further. So you not only lose the parasympathetic output, but you're also losing some of the sympathetic output. So the autonomic system as a whole is depressed. Make sense? Now, let's go back to that blood pressure. So why was that such a big deal? Because I remember I talked about it before where I read it out, like we do bilateral blood pressure. So what? I'm sure some people looked at it and be like, wait, that's weird. Why is it different side to side? Because there's differences in vascular resistance side to side. So before we go into that, let's review how the blood pressure is controlled through the medullary nuclei. This is like what we did last year. If you have increased arterial pressure, creates increased impulses of cranial nerve 9 to the carotid sinus, excitation in the nucleus tractus solitarius to dorsal motor nucleus of 10. Remember, there's also fibers from smell that go there. So we can start to put this picture together. That increases impulses to the heart from dorsal motor nucleus 10, which means they're parasympathetic impulses, which slow heart rate. So in other words, when there's increased arterial pressure, you start slowing the heart rate. When you increase blood pressure, though, you're going to have increased impulses of cranial nerve 9 again, which is going to have excitation in the caudal nucleus tractus solitarius, which is going to increase firing of inhibitory neurons to the preganglionic sympathetic neurons in the thoracic cord, lowering blood pressure. So there's two different reflexes that keep these things in balance. And if we're having an issue with pulse is escaping, that we know there's an issue somewhere along that nucleus tractus solitarius or dorsal motor nucleus 10, or cranial nerve 9. My guess, because we don't think there's ablative problems to cranial nerve 9, that it's that excitation in the NTS to cranial nerve 10, something going on with the dorsal motor nucleus of 10 that's not really helping out here. So clinically, do the angulation of the ascending aorta, how your heart is on the left side, it dumps to the left, and the smaller number of branches into the arms to the left compared to the right, blood pressure should actually be 5 points higher on the left when compared to the right. For the record, this is something that I learned from people I learned from. It's not, I'm continuously looking for the source that says that, but I know that cardiologists that I've spoken to have said, yeah, they've heard loosely of that, but they don't really care too much about it. They only care if it's like 20 points different, or I'm sorry, if it's more than 10, 15 points different. But we use it clinically and it's worked out so far with us as a good data point. So revisiting the case, if when seated, the left was 154 and the right was 150, is that 0.5 points higher on the left? No, 4 points. Does that mean that the left side is slightly too low or the right side is slightly too high? Now, when we go from sitting to standing, we would want them to go up approximately 10 points evenly. Do they do that? The left side goes from 154 to 159. The right side goes from 150 to 158. Do either of them go up 10 points? No. So if blood pressure doesn't increase enough, then your brain is going to, what is your brain going to fire in order to do the rest? Pulse. It's going to increase your pulse. If you have 154 going to 159 or 150 going to 158, look at that. The left side, which was supposedly higher and a little bit almost normal, does not respond as well to changes in gravity as that right side. That right side goes up. That left side goes up a tiny bit. So it's still higher on the left, but I wouldn't say that that's like normal or good. I would say there's something going on there. So when we do functional orthostatic blood pressure, we talked about this before. We're not waiting that full minute, and that would be done during true orthostatic measurement. We measure right away. We want to see how well the brain is responding to functional changes. So when challenged with gravity, the left increased at a lower rate than the right side. That's what's going on in this case.
Hey, Doc.
So yep.
We have a hand raised. Do you want to take the question now or you want to wait till later?
Yeah, of course.
Okay, let me unmute them. Hold on. Sean, you can go ahead when you're ready. Needs to unmute it. Well, I guess just may as well just resume. He doesn't seem to be available at the moment.
Yeah, if he comes back, and maybe you can just have him type into the chat and just interrupt me and let me know that it's in there.
Okay.
Unless he wants to ask it. Either or works. Okay. So one of the key questions in this case so far is when you see a dysautonomia without this textbook value, we're just calling textbook in quotes because I don't have a source for it yet. You must question the following specifically for this case. Is the left too low or is the right too high? So then the question is, how do you figure that out? Other autonomic tests. What other autonomic tests are part of the cranial nerve exam? SpO2. It's a measure of peripheral capillary oxygen saturation, or the amount of oxygen in the blood. Specifically, it measures oxygen-bound hemoglobin. So if you're measuring oxygen-bound hemoglobin, you need to make sure that the hemoglobin, there's enough iron and hemoglobin going on in there to begin with. So if you see low oxygen numbers, you got to think right away, okay, low oxygen numbers, do I need to run an iron panel? And I would recommend running all 5 iron panels, like the whole panel with ferritin. Normal pathological range is 90 to 100%. Oh, I'm sorry, one more thing on iron. If you find that iron is low, sometimes you just give them iron. You have them cook with a cast iron pan, you have iron supplements, and they're good. It's easy, but you get iron, and they get better. But if normal pathological range is 90 to 100%, functionally at sea level, I want to see 98 to 100%. At 5,000 to 6,000 feet where I am, I'm okay with 97 to 98%. But if you're below 97, I'm like, you're not getting enough oxygen in your periphery. Now I got to check your lungs. Do you have enough oxygen coming into, are your lungs working? Are you getting oxygen in? Then I got to think, okay, well, you know how like the gut barrier is a mucous membrane with stuff that you got to like have integrity of. So is your lung barrier. So we were like, okay, well, how inflamed is she in her lungs? And then I got to say, okay, well, now after that, is she's getting the oxygen into her bloodstream, is it getting and attaching to heme, and is it getting over and are you getting in the periphery? Is there something sympathetic going on that's preventing you from getting in there? So I look at this short answer as a sympathetic measurement. How sympathetic is it? The lower the number, the more sympathetic you are because it's constricting your blood vessels and you're getting less oxygen to the area. But we correlate it with perfusion index. Perfusion index is a calculated number. It's calculated as a ratio of the pulsatile blood flow to the non-pulsatile blood in peripheral tissue. What it means is that this helps us determine if SpO2 is accurate because if perfusion index is lower than 0.4, like I was saying before, SpO2 is considered unreliable. And it has a high correlation to capillary refill time. So you can sit there and you can push on things side to side and compare if the lighter color goes to a darker color. But I'd rather just use an SpO2 and perfusion index just to calculate that. And so when we're revisiting this case, the seated SpO2 perfusion index was 95 seated and standing. In other words, after a movement, that oxygen did not get better. That's weird. It also means that she is not getting enough oxygen to her periphery to begin with because it's at 95%. When going from seated to standing, there's preference in the pulse direction of blood bringing oxygen to the tissues, right? Let me repeat that. When going from seating to standing, there's preference in the pulse direction of blood, bringing oxygen to the tissues, going into the left side of her body. So what can we infer as answers to our key questions yet? Decreased oxygen to the periphery on the right would be more associated with parasympathetic activity. Increased blood pressure on the right would be more associated with sympathetic activity. So we have no answer yet. Right now we're seeing mixed things going on. We have to correlate it to more brain areas. This is why you can't take one measurement and say, oh, they're sympathetic. So what other autonomic tests are part of the exam? Pupillary light reflex, and I've already talked about this app. So this is the graph that we got pumped out. So right away, which pupil is larger? According to when we did this, the left. Over time, which best fit line would show more fatigability? The left. Now, here's the thing. We threw her in goggles in the dark and her right pupil was bigger. So when there's no light stimulus, her right pupil is bigger than her left pupil. When there is a light stimulus, her left pupil reacts less than the right pupil because it's larger. It doesn't shrink as much. So, or it doesn't shrink initially as much. So the size of the pupil is different, whether there's ambient light or not. So when she was talking about light sensitivity, her left pupil just is not reacting to light as much as it needs to, because we know when there's no light, that right pupil gets bigger. Fatigability in holding the pupil small. Okay, well, oh, sorry. So looking at this graph, what you want to see is the pupil get small and then gradually increase and release after 5 seconds. 4 to 5 seconds is like normal fatigue time for us. Well, if you look at this and you want to draw a best fit line, which best fit line would show more fatigability sooner? That left one for sure. So we know there's something going on with that left pupil. The left autonomic system is where we should focus our attention based off of what's going on. So right now we're leaning towards, now here's the thing, you don't live in a higher sympathetic state. You don't live in a higher parasympathetic state. You live in a dysregulated sympathetic parasympathetic state where it swings both ways, which means less regulation of it on one side versus the other side is what you're targeting, not we're gonna do sympathetic or parasympathetic activity. You may have thought at some point she's got insomnia, she's got some vagal nerve issues that we pointed out already with dorsal motor nucleus of 10. Why don't you just do vagus nerve stimulation? We'll get to that in a little bit, because in this patient, it will probably make issues. Vagal nerve stimulation is not a panacea. Okay, so sorry, I get a little fired up with that one because there's a Facebook group with like 6,000 members in it, because this guy who started putting out education for why vagal nerve stimulation is basically good for everything, or all these vague neurological symptoms. And he's literally like just giving enough information to sell his product, and he's giving this to all these people who have insomnia and sleep apnea and all these problems that you should not be using vagal nerve stim for. But we'll get to that in a second. All right, so fatigability and holding the pupil small means either escape of the sympathetic system or failure of the parasympathetic system. Either way, there's both dysregulation. I talked about that note already. So which areas fire into the autonomic control centers to help maintain modulatory control? So this is the question that we want to answer. It's not, are they sympathetic or parasympathetic? We have to answer, what system that fires into the control centers isn't working right? So your hypothalamus. Hypothalamus activates by the dorsal longitudinal fasciculus. It activates brainstem parasympathetic nuclei. It activates your reticular systems, your periaqueductal gray matter for pain modulation. It slows your heart rate. It lowers your blood pressure. It increases digestion. It increases respiration. It increases salivation. Now, these are all things that we typically think of as, oh, these are all parasympathetic. They're technically parasympathetic in nature because it travels over those fires, but they're technically hypothalamic projections and activation of the hypothalamus. So the hypothalamus activates by the mammalotegmental tract regulation and processing of visceral function. Both the dorsal longitudinal fasciculus and the mammalotegmental tract have feedback loops with viscera. So in other words, when we're looking at organic loops that say, hey, organs, do this thing. Hey, organs, tell me what you did. Hey, should we do it more or less? It's your hypothalamus that measures that. So you may, if you work in any sort of like functional medicine world, you may harp on the hypothalamic pituitary axis for the adrenals or for the thyroid. Don't forget that the hypothalamus could be the issue, not the thyroid and not the adrenals, and you might be chasing adrenals or thyroid when that's not the issue. Decreased cortical activation of the ipsilateral hypothalamus. What does that do? So when you have decreased activation of the thalamus on the left, you're going to have pupil dilation on the left. You're going to have reduced nasal secretion and dry eye on the left. You're going to have reduced saliva on the left. You're going to have reduced intestinal motility and digestive enzyme secretion on the left. So you got to know where cranial nerve 10, where left innervates and where right innervates for the integrity of the gut. Your decreased ipsilateral hypothalamic tract inhibition of the IML cell comp. In other words, you're also going to have decreased inhibition of your sympathetics on the left, which increases sympathetic tone, increases heart rate, increases blood pressure, increases pain sensitization, peripheral vasoconstriction leading to poor circulation, and increased sweating. So you can see how there's, depending on the presentation, you can figure out where the lesion is. Okay, I didn't lose anybody yet. Do we have any questions or anything like that?
Not seeing any questions, Don.
Okay, cool. All right, we're gonna keep going into cerebellum. So remember, another thing that fires into the hypothalamus to promote control over your nervous system is your cerebellum. Now, remember I talked about that before, it's not only coordination and balance of movement, but it's coordination and balance of thought. If you have somebody whose mood swings all over the place, do some cerebellar tests, see if there's a deficit. Maybe they need exercise on one part of their body and not the other to balance it out, and then they'll actually have like an easier way to get through it. So your cerebellum receives input from muscle spindles, and they can do some exercise. You can do one-sided exercise, other-side exercise. You can also use vibratory stimulus on one side of the body and not the other. Cerebellar input. Your frontopontine fibers, so fibers that come from your frontal lobe to your pons, and your vestibular nuclei all go to the cerebellum. So in other words, if you have unilateral vestibular deficits, your cerebellum may also be struggling as well, and you may need to increase. Okay, so let's think about it this way. If your vestibular information is at a deficit and your cerebellum is requiring that vestibular information in order to fire other things, and now you have less vestibular information, then this parts of the cerebellum that receive that vestibular information is also going to be decreased. So you need to increase vestibular information, and you need to increase the cerebellar part that fires to then control downstream things like the top of the brainstem and the frontal lobe. Make sense? Things that can injure the cerebellum, any sort of cerebellar injury, concussion, stuff like that. Hypoxia, very dense cells in the cerebellum. Hypoxia is a big deal. What things can create hypoxia? Full anesthetic all over the body. Degeneration can create hypoxia from alcohol, or you can also just like suck nutrients from too much inflammation going on there. If you have gluten autoimmunity, you know, when you're testing for Crohn's, you're testing for 1 transglutaminase, but there's 8 of them, and 3 or 4 of them are in are in the brain. 2 of them are in the cerebellum. So if you've got something going on, you can have gluten sensitivity of the brain and not have gluten sensitivity of the gut. So it may be good to test that stuff. If you're like, hey, every time you eat a pizza or every time you have some sort of bread, you just get weird, like your mood gets weird. That's probably cerebellar mood coordination control, not, oh, my gut's inflamed, so now I just feel bad. GAD autoimmunity can also be from gluten, and they can also GABA imbalances. This is why I do not recommend using GABA as a supplement ever, because you can change the functionality of the brain. You can change the functionality of the cerebellum specifically because it relies so much on GABA. You want to get the cerebellum to control itself, not be dependent on exogenous GABA. Symptoms. You can get vertigo from cerebellar issues. You can get motion-induced nausea from cerebellar issues. You get poor spinal muscle stability issues. So if you're working on their core and they have like some poor spinal muscle stability stuff, and then they're like, oh yeah, I can't like get a ride here. I have to drive because I get nauseous if I'm in the car with somebody else driving. Think brain, not body. Changes in functional balance between the deep cerebellar nuclei and the Purkinje cell layer creates downstream changes in the midbrain. Increasing activation of the intermediolateral cell column also can create control over it because of that Purkinje cell layer. And cerebellum fires to midbrain neurotransmitter nuclei, which relay to the frontal lobe. And this is anxiety. This is implicating anxiety and depression, as I went over earlier. As a recap, when you have these neurotransmitters being shoved into the frontal lobe through cerebellar activation, your cerebellum needs to be able to control its own output of the deep nuclei because the Purkinje cell layer should just say like, okay, we let a little out, not where just this much, not, oh, just keep firing, because that's going to excessively fire your midbrain, which is going to excessively fire your frontal lobe, which is going to chew up your frontal lobe from too much activation, causing anxiety. What do you do about anxiety? Movement and activation to create more Purkinje cell control over the cerebellum to slow down the amount of firing coming through to when you need it. What's a good way to get Purkinje cell activation? When you do some sort of, this is what we use gaze stability for, when you're looking at a target and you're slowly moving your head back and forth. Anything that involves visual fixation while you're doing an exercise creates Purkinje cell activation. Okay. So you've got somebody at the gym, they're doing squats and their eyes are darting all over the place and they're creating a ton of activation. Get their eyes on a single target and be like, you need to keep your eyes here. If your eyes are jumping all over the place, you're going to chew up your frontal lobe. Okay, sympathetic effects. This is stuff that most of you guys already know, but I feel like it's a good reminder. Fight or flight, activation of the IML from T1 to L2 or 3 results in norepinephrine release from the postganglionic fibers and epinephrine release from the adrenal medulla. So sympathetic, yes, globally, will create adrenal medulla activation through the HPA axis. However, in reality, we've already discussed this. Is it too much sympathetics? No, we have to think about it as too much or too little hypothalamic activation. But this is something I wanted to bring up, which is specifically mass activation prepares for intense activity through increase in heart rate, dilation of bronchioles, and burning of glucose rapidly, increasing your glucose demand. So if you're living in a state where if your hypothalamus is decreased, which is allowing sympathetic effects to fire more naturally or more readily, what this means is that you're getting sympathetic effects all over because your sympathetic fires as one single unit over your entire body. That's how it responds quickly to a tiger or a bear. It says, whole body, we do this. It doesn't say, okay, well, let's figure out what systems we need. It does all things at once. It also burns through your glucose. And if you have blood sugar destabilization, that will loop on itself, where it will now cause more blood sugar destabilization because you need to have glucose in order to fire the neurons that control it. If you're burning through the glucose to do that, then you're going to end up having hypoglycemic events, which is then going to create more mood dysregulation and more symptoms. Now, this is what I was hinting at, which is parasympathetic effects the parasympathetic system usually not activated as a whole. It's where separate parasympathetic nerve bundles will activate it individually. Does that make sense? So if your sympathetic is going to fire all body all at once, your parasympathetic doesn't usually fire all body all at once. It usually fires to control certain little aspects to keep things in balance. And it usually does it through a release of acetylcholine. And that usually has is considered a relaxing effect, where you decrease your heart rate, you dilate your visceral blood vessels, and you increase digestive activity. That's the basic stuff that everybody knows. But coming back to it, but when you come back to it, it all comes down to those hypothalamic reflexes, those cerebellar reflexes, the things that fire into the brainstem that control that, the things that fire into the brainstem that control that that control that sympathetic output. So instead of increasing parasympathetic, we're just reducing sympathetic. That's what the goal is with a lot of these therapies. All right, it's 6 o'clock, so 8 o'clock your time now. Let's do 5-minute break. If anybody has any questions, please type them into the chat. I need to use the restroom real quick. All right, I'm back. Any questions?
Hey, Doc, it's me. Just a quick question. We had kind of put it out there that this would be a 2-hour thing, Monday, Tuesday, and then 2 hours Thursday. I
Sure.
guess you're welcome to continue going, but I'm just telling you what we had told our members that this would be for tonight. So I don't know if anyone else had made plans beyond 8 o'clock.
It depends. How about we do it this way? There's 12 people here right now. We'll go based on what they prefer. We can keep going and just get through the rest of the case, or we can do 2 hours on Thursday. It doesn't matter to me either way. Do we have, if we get like a simple majority, so we have 10 people here, if we get 6 people to say they want to keep going, then I'll keep going, and then the other people can just watch it as the recording. Does that sound fair?
It seems fair. How do you want them to vote on that? Raise their hand?
Yeah, raise a hand if you want to vote yes, keep going.
I have one hand raised. Still one hand.
I appreciate the enthusiasm from the one guy so far, or guy or girl.
We have two hands.
Sweet.
3 hands.
I don't know if anybody stepped away, so I'm just gonna repeat it again in 1 minute at 8:05. Just to let people know what we're doing with the hands raising.
So if anyone would like to continue, just need you to raise your hand. If not, we will continue this on Thursday at 6 o'clock.
I'm sure you guys want to, like, I'm going to go through actual like treatment, what we did with the patient and show results and stuff like that. It'll get a little fun too. So might be, some people want to wait, some people don't.
Well, I'm still looking at 3 hands.
All right, let's do it this way. If there's, just to make sure that we're not just people stepped away or people aren't answering. Maybe we'll try and go 6 the other way. If you can type into the chat, wait, if you want to wait, just to make sure that we're hearing from everybody. We're not just assuming that people are here. 2 waits. You got a 3rd wait. Okay, so we're tied up there. All right. Why don't we wait? Let's do that. We'll pick up where we left off. If anybody has questions, bring them on Thursday, and we'll have time to also answer questions as well about cases you have, about this case. If any jokes, we can do that too. Okay, we've got ready to continue. Okay, yeah, we're definitely gonna wait then. It looks like that's where we're headed. Ty goes to wait.
Okay.
All right, so what are we picking this up again? 4 o'clock my time, 6 o'clock your time on Thursday?
Yes.
Let's do it. All right, cool. If anybody has any questions, you can always shoot me an email. I'll type it in here.